Good day, everyone. My name is Glenn Pierce. I'm the Vice President of Medical for the World Federation of Hemophilia, and welcome to the World Federation of Hemophilia webinar series on shared decision-making. This is a three-part series. Today, we'll be covering mechanism of action of hemophilia replacement therapies, and next time, on March 12th, we'll be covering more about the safety issues related to the various treatment products that may be available. And then the last time we'll be talking about the process of actually using the shared decision-making tool. Next slide, please. I've introduced myself. It's a pleasure to be here and to welcome our guest speakers today. Let's first look at the agenda. Next slide, please. And on the agenda, we'll start with a discussion by Barbara Konkle on factor replacement therapies, and then we'll move into non-factor replacement therapies with Steve Pipe, and then we'll talk with two patient advocates, Hazri Aris and Enrique Preza, who will talk about their roles in looking at shared decision-making and open this up to questions and answers then for everyone. This is the shared decision-making tool. The QR code for it, which we'll also display at the end of this, should anyone wish to look at this in advance of the next two webinars. Next slide, please. I'm going to go ahead and introduce all of the speakers now. So our first speaker will be Dr. Barbara Konkle, and she is the professor of medicine at the University of Washington in Seattle in the United States. And she's also currently on the board of directors for the World Federation of Hemophilia. And she co-chairs and has co-chaired for a number of years now the Scientific Advisory Board for the World Federation of Hemophilia Gene Therapy Registry. Steve Pipe, Dr. Steve Pipe is a professor of pediatrics and pathology at the University of Michigan. And he's the medical director of the coagulation program there and of the Special Coagulation Laboratory. He's the former chair of the National Bleeding Disorders Foundation Medical and Scientific Advisory Council, MASAC, and has been very active with the WFH in the humanitarian aid program as well. Our two guest speakers who are both patient advocates. Our first is Hazri Aris. He's a person with severe hemophilia, and he's currently working at the WFH as the regional manager for Southeast Asia and the Western Pacific. He has a passion in advocating for comprehensive treatment and care for people with bleeding disorders, and has been a longtime volunteer for the Hemophilia Society of Malaysia since 2006. And our second patient advocate is Enrique Preza. Enrique has hemophilia as well as high titer inhibitors. He's in Mexico, and he's collaborated with the WFH in the Gene Therapy Roundtable and on WFH guidelines. And he's currently working with WFH on the Living Guidelines Model Oversight Committee. In Mexico, he has been the co-founder of a company dedicated to improving education in Latin America. So those are our speakers. If we have the next slide, please, I'm going to turn it over to Barbara, but first we're going to do a poll. And so let's see. For the poll, you are a 60-year-old male with hemophilia A without inhibitors and have been on on-demand treatment with standard half-life products your entire life. Based on what you know now, what treatment would you choose for yourself? Your response choices include continue with on-demand with standard half-life or extended half-life products, prophylaxis with standard half-life or extended half-life products, prophylaxis with an ultra-long half-life such as Altuvio, bispecific antibody such as Hemlibra, a rebalancing agent such as concizumab, or gene therapy. And here is your poll. So please mark one of those. All right, thank you. And we'll take a look at these, I think, later, but we will now move on to Dr. Barbara Konkle, who will talk about factor replacement therapies. Next slide, please.
Okay, it's my pleasure to talk to you today and give an overview of factor replacement therapy. Let's see. Oh, I will get this going. Okay, these are my disclosures. So hemophilia A is an X-linked bleeding disorder due to a deficiency or dysfunction of factor VIII. And the prevalence at birth is about 25 cases per 100,000 males, and about 10 of those have severe hemophilia. Females are also affected, usually with mild hemophilia, although it can be more severe, and about 30% who have genetic variants causing hemophilia have levels within the hemophilia range. So shown in the upper right hand is the factor VIII protein as it's processed to become an active protein. And I put this here in part to note that there is in the middle a B domain, which is cleaved out and is not present in the active protein. And that would be important later as we look at the products. And shown in the lower right is a coagulation schema showing factor VIII in its role of bringing factor IXA together with factor X, resulting in 10 activation in the prothrombinase complex, thrombin formation, and ultimately a fibrin clot. Hemophilia B, also an X-linked disorder and overall distinguishable from hemophilia A only by laboratory testing, is due to a deficiency and/or dysfunction of factor IX. It's much less common than hemophilia A, with 5 cases per 100,000 males. About 1.5 of those are severe, and given the X-linked nature, also females are affected. Shown in the upper right is the active, what happens for the active factor IX protein, and shown also is again the coagulation cascade with factor IX being activated and then resulting in the activation of factor X, thrombin formation, and a fibrin clot. So here is an overview of the history of factor replacement, development in hemophilia. Blood transfusions were first used in the 1930s, with plasma in the 1950s, but plasma is very inadequate for both factor VIII and factor IX. They're present in plasma at 1 unit per milliliter, so you can't really give enough plasma to get an adequate level for most bleeding and procedures. In the 1960s, we had further enrichment of plasma in cryoprecipitate, which enriches factor VIII and von Willebrand factor, as well as fibrinogen and factor 13. It does not contain factor IX in an enriched amount, but carries issues related to viral safety and use, which we will talk about at the next time. And then in the 1970s, we had our first plasma-derived factor VIII, and then factor IX, and then recombinant factors and modification of recombinant factors, which we will talk about more. So what we want to do, and I think what we are achieving, is taking a boy who's casted in the summer so he doesn't injure himself to people who have a full range of activities and a normal life. So in terms of plasma-derived factor products, factor VIII is purified from plasma or cryoprecipitate. It may contain von Willebrand factor, and if it does, then it can be used and is used to treat von Willebrand disease. Factor IX is purified from plasma. Initially, treatment for hemophilia B was with what prothrombin complex concentrates. And these contain all of the vitamin K dependent proteins, which are shown at varying levels. But usually the factor IX activity is noted on the product. And that really relates to its history in hemophilia B treatment. We can use these products to treat the very rare, some of the rare clotting disorders, factor II, or prothrombin deficiency, factor X deficiency, if the factor X concentrate is not available. Factor VII levels are variable, and it usually factor VIIa is now used, if available, to treat factor VII deficiency rather than a PCC. And then there also is a purified factor IX, such as monoclonal antibody purified. So viral transmission, we'll talk about more next time, but there was transmission of hepatitis and HIV through plasma-derived products in the past. Plasma-derived as well as recombinant products undergo viral inactivation steps, which can include one or more heat, solvent detergent, pasteurization, or nanofiltration, and these have been effective in eliminating transmission, but this still is something we need to be very diligent about. And still, with use of unmodified or cryoprecipitate blood products, particularly in countries where transfusion-transmitted diseases persist. So the gene for factor VIII was cloned in 1984 and for IX in 1982, which allowed the production of recombinant products. The first FDA-approved product in the US was in 1992. Cells are grown, or the product is grown in a cell line, either of hamster or human origin, and then purified. And shown on the right is a process for teroctocog alpha, which shows the propagation and then expansion in bioreactors, and then purification, which takes several steps, and then nanofiltration to be sure that there are not viral contamination, and then further purification. Early products contained human albumin as a stabilizer, and as noted, they still go through viral inactivation steps. So standard half-life recombinant factor VIII products may be full length, may be B domain deleted, and there's one product that is single chain. And shown in the picture is a B domain deleted product. The half-life of factor VIII is approximately 12 hours. It is shorter in children, particularly in preteen on down, and we'll see some data on that. There's overall, the half-life is about 12 hours, but there is inter-individual half-life variability, and a significant influencer in that is the von Willebrand factor levels. So shown in the cartoon on the upper right, almost all factor VIII is bound to von Willebrand factor. And so the half-life of von Willebrand factor affects the half-life of factor VIII, which is very good in that if someone has severe von Willebrand disease and no von Willebrand factor, we know they have very low factor VIII levels. But that has also affected our ability to prolong the half-life of factor VIII, which I will address in future slides. Shown in the lower right is results from half-life. Shown on the left is the factor VIII activity, and on the x-axis time after the dose. So you have an increase after the factor is given, and then a gradual decrease. And this was looking at data from two different products, extended half-life products, a lactate and a Dynavate. And you can see that the blue and the green curves are basically superimposed. But what is remarkable is if you look at all the the black dots and the clear ones of the two products as the factor VIII varied per individual. There was a lot of variability between the individuals. So one way to understand a patient's levels is to do a pharmacokinetic study. And those can be quite extensive and require multiple blood draws. And so what has happened is this has become much easier to get an idea of half-life using what's called a population PK. So shown in the panel, and this is from a presentation given by Alfonso Ioria, who has really done a lot of work in this area and made this tool available through WAPS Hemo, which the address is shown, the web address is shown on the slide. So in the dashed line is the half-life of the product at the dose given based on data we have from that's available in the literature on individuals who received this product. And then the red line, there are 2 points, and those are just 2 points, blood draws from the patient. And then we can put that on, superimpose that on the dashed line to determine that individual's how long half-life or how long the factor will stay in circulation. And then based on the dose can predict, which is shown in the solid line, what the peak and half-lives will be. The top part of the figure shows what results from an individual who's taking factors, say Monday, Wednesday, Friday, and then missing a day over the weekend. And shown in the bottom is an every other day approach. So standard half-life factor IX products are full-length recombinant factor IX. They have a half-life of 18 to 24 hours. It varies in part because factor IX is not only inside the vascular pool, inside the vessel, but also has an extravascular component where it's bound to type 4 collagen. And this affects the pharmacokinetics, how long it stays in circulation, and also the extravascular component is thought to have a hemostatic role. So the extended half-life factor IX products we have, and really the development of recombinant products, a key thing that has evolved from that is then that allows the modification of the product to prolong the half-life and thus to have fewer infusions. So the modifications, so the FC portion of the immunoglobulin molecule, albumin, and pegylation. And pegylation is protects the molecule from degradation. And so the half-life from a 12 to 24 hour is significantly prolonged. And there is some decrease as you decrease age, not as much actually in these products as in factor VIII products. And so in terms of the mechanism for the FC and albumin mediated prolongation, there's a process associated with the FC neonatal receptor, it's called, which is present in endothelial cells. And this is why immunoglobulin and albumin are so stable. A reason they're so stable in our blood is that they get taken up, proteins get taken up so that eventually they're degraded. But what the FcRn allows is that they go through, they bind the receptor in the acidic endosome, and then instead of going into the lysosome and being degraded, it is recycled via this receptor and then dissociates when it gets back to physiologic pH. And so this recycling prolongs the half-life of these products. So for the extended half-life factor VIII products, which are shown here, there is an FC fusion to a B domain deleted product, and then different pegylation approaches. And then the bottom one Altuvial we'll talk about a little more, which has more modification. If we look at the top 4 products, there is prolongation from the approximate 12-hour half-life, which does allow less frequent dosing, but it's not the prolongation that we see with extended half-life factor 9 products. And you can see that these products, if you go back in terms of age, that the half-life is shorter in particularly young children. So this is FNS octocog alpha, or the brand name is Altuvio, and the structure is shown here. The blue part are the different parts of factor 8, and connected to that is the FC domain. So that is a lactate or a lacta. And then in addition, they've added the part of von Willebrand factor, the D' D3 domain that binds factor 8 to make this molecule independent of factor 8. And then they've also added X10 insertions, polypeptide, which protects the molecule from degradation, kind of similar to what PEG molecules do. And so this has been studied. This is our results from a phase 1/2 study looking at a standard half-life factor 8 shown in the pink, bright pink, a standard extended half-life in blue, and then FNS octocog alpha shown in green. And there are 2 things. One, the half-life is significantly longer. And then if you look at the top of the green curve, and so it shows that up to day 4 in this 50 unit per kilogram dosing, the factor level stays above 40%. And because of the shape of the curve, if you look at the area under the curve, which is shown, that is particularly prolonged. And so that would be the amount of factor 8 exposure. So we talked before that the factor 8 half-life is dependent on von Willebrand antigen, and the goal with FNS octocog alpha was to make it independent. And on the left hand is shown patients received plasma-derived or recombinant factor 8, and their factor 8 half-life shown on the y-axis compared to the antigen. And the relationship is shown. Those with higher baseline von Willebrand antigens have a longer half-life. Shown on the right with the straight black bar shows that that relationship is not present with FNS octocog alpha. So the result of the phase 3 trials, which was published last year for individuals over 18 and published later in the pediatric trial, that the annual bleeding rate, the median was 0 with a mean of 0.71, so less than 1 bleed per year. The key secondary endpoints. So most of the individuals in the study who were on prophylaxis prior to the study were part of a study where they followed them for their regular factor 8 prophylaxis and looked at how much they bled. And so the mean ABR in that time was about 3. And then on the FNS octocog alpha, it was 0.69. So a significant reduction in ABR from their prior prophylaxis. So approach to treatment in hemophilia, what do we think about? Well, prophylaxis we know is key. So there are definitions of prophylaxis. This is from the WFH guidelines. Primary prophylaxis is regular or continuous prophylaxis started in the absence of documented joint disease, which can be determined by physical exam and/or imaging studies, and before the second clinically evident joint bleed, and before 3. So secondary prophylaxis is also continuous, but initiated after the onset of joint disease and usually a little later in life. And then tertiary prophylaxis is beginning after the onset of documented joint disease, and this would apply to people, adults in the places that have had access to factor for some time, or really any individuals with significant joint disease. And the figure below is from the follow-up study from the joint outcome study led by Marilyn Manco Johnson. And that was a study that compared prophylaxis to on-demand treatment and showed the superiority of early prophylaxis. So the individuals who were on demand were encouraged then to go on prophylaxis at the end of the study. And this shows those two groups being followed. And I really have two takeaways from this. So the blue shows that the percentage with joint failure, which may not be what we think of joint failure, but the definition of joint failure here is evidence of joint damage by MRI or need for joint surgery. And so the comparing the blue to the red, can see that the joint status was much better at age 6 at the end of the study and continued to be better at age 18. But my takeaway also is that even this prophylactic regimen, which was with standard half-life factor every other day, was also allowed joint disease progression, and we need to do a little better. So what about the goal? What is our goal with factor concentrate prophylaxis? So traditionally, this was to stay above 1%, knowing that patients with moderate hemophilia generally had less joint bleeding than those with severe hemophilia. But we've learned since then that that's not enough for many individuals if we have factor concentrate available for treatment. The WFH treatment guidelines suggest a trough of 3 to 5% or higher if factor is available. But studies in patients with mild hemophilia show higher levels is needed to prevent all bleeding. And here are two studies, the top one from the Netherlands, and this is on patients with mild or moderate hemophilia, showing the number of joint bleeds at different factor levels. And it really approaches 0 around 15%. In the lower right is a study from the US CDC looking at both hemophilia B in blue and hemophilia A in red. At different ages, there was more variability in this study, but also showed around 20% or so where you approach 0. And there was a more recent Italian study also showing similarly. So does this mean that everyone needs a trough of 15 to 20%? I don't think so, but it speaks to the variability in bleeding and that we need to design regimens for the individual to prevent bleeding. Also, we know that in countries where resources are limited, that lower dose prophylaxis that don't reach any of these goals can prevent joint disease. And that is also an important approach. Studies have shown that quality of life is improved by prophylaxis, both when started early, but also in adults or others with established joint disease. So bleeding. So the important aim for treatment is really twofold. And I'm not going to go through all of what's on this table, just to note that this is in the WFH guidelines. But the aim is really twofold. And I think the second part sometimes can not be recognized as much. So first, we want to treat bleeding, and we want to treat it promptly, but we also want to treat it adequately to prevent bleed recurrence, limit complications, and restore tissue to rebleed state. So when the bleeding is controlled, we need a regimen, and it really is based on where the bleed is and the severity of bleed to continue treatment for a period of time. And the second important thing is home infusion, because that allows prompt treatment of bleeding. So in terms of surgery, we also want to prevent bleeding during surgery, and we also want to continue treatment to allow healing. So the dosing varies from factor VIII to factor IX because of the extravascular component for factor IX. So for standard factor VIII, we have a 2-unit rise per kilogram for each unit of factor VIII given. And for factor IX, it's approximately 1, although it varies more by product. So shown on the right is just a crude sketch of if we give 50 units per kilogram, we would go to 100%. This is a standard half-life product. We would expect in 12 hours for the level to be around 50%. So by giving a 25 unit per kilogram dose, we could then continue to keep the level above 50%. However, if someone's having major surgery, there's blood loss, there are a number of factors that can affect factor VIII survival. So it's really critical in major surgery that we can measure factor VIII or factor IX levels to be sure that hemostasis is adequate, particularly for those early times. We can also give factor by continuous infusion, which is shown in the red line. Major surgery should be performed in a setting not only where there is hemophilia management expertise and experience, but also an experienced surgeon, a pharmacy with factor support, and an on-site laboratory in order to give real-time factor measurements. And just here is an excerpt again from the guidelines showing recommended surgical levels and the length of time for continued treatment to maintain that hemostasis and healing. So I'm not going to talk about inhibitors today. I'm going to do that at the next session. But just to say, we know this is a significant issue, particularly in individuals with severe hemophilia A who are treated with factor VIII, but also occur in hemophilia B. So what factor products do we have to treat patients with inhibitors? So we have activated prothrombin complex concentrates. So those are PCCs that have had partial activation. The specifics of this are not published. So early studies, actually before my time even, there was really no treatment for patients who developed inhibitors. So prothrombin complex concentrates were tried and showed some efficacy. And then the activated PCCs were used, which probably show a little more efficacy, although I must say there's not been a direct comparison of those. We also have recombinant factor VIIa, and we have non-factor and rebalancing agents, which Dr. Pipe will discuss. So in terms of PCCs, there was a study comparing home treatment of bleeds in patients with severe hemophilia A with inhibitors. Either they were given an APCC, and then for the next treatment, recombinant VIIa, or the opposite. And so they compared how they did. And the blue, solid blue, were rated as effective. And if you look at this, they look like they worked about the same. And they did overall, but of note in individual patients, sometimes the APCC worked better and sometimes the recombinant VIIa worked better. And so they couldn't call them equivalent. And I think that mirrors our practice in that some patients respond with inhibitors respond better than one to the other. But the other striking thing about the study is how really inadequate this treatment is in terms of giving effective treatment control. There have been studies using these products for prophylaxis. So this is a study with recombinant VIIa, where it was given daily, either at 90 micrograms per kilogram or 270 micrograms per kilogram. And shown in the left figure, you'll see that these patients bled a lot. It's not an ABR, it's the mean number of bleeds per month. And on the prophylaxis period with either dose, they had a decrease in bleeding but still significant bleeding. Shown in the right panel that shows that this was true, traumatic or spontaneous bleeding. And then there was a randomized trial with APCC, the APCC FIBA. This was every other day treatment. The dark bars show prophylaxis. Again, there was a decrease. This is an ABR, so an annualized bleeding rate. So these individuals did not bleed as frequently as the other, but still they had significant bleeding, which was significantly decreased, but still there was bleeding. So these approaches for prophylaxis with these products, I mean, did produce and can produce some clinically significant outcomes, allow patients to rehab, but I think also shows the inadequacy of our treatment of patients with inhibitors. So in summary, plasma-derived and recombinant factor replacement products are used for treatment of hemophilia and other bleeding disorders, and choice and dose of product will depend on availability, treatment goals, and patient-related factors. Prophylaxis, either with factor replacement or with other products, which you'll hear about, started early and continued through life, is key to produce optimal outcomes in hemophilia. And for patients with inhibitors, non-factor therapies improve outcomes, which we'll also hear about. Although with our current other products, we still need factor products for treatment of bleeding and surgery. So at this point, they remain key in treatment. Thank you.
All right, well, thank you for setting that up, Barb. And I'm going to now give our next section where we're going to be covering non-factor therapies. And then at the end, we're going to cover some of the principles of gene therapy. It didn't actually include a disclosure slide in this presentation, but should let you know that I've either served as an investigator or a consultant on all the clinical programs we're going to talk about today, but I have no personal stake in their utilization. So one of the things we want to understand about the current platforms of therapy is that there still remain significant disparities in health, quality of life, and access to prophylaxis for people with hemophilia across all geographies. These advances in prophylaxis options have been great, but health equity really has not yet been achieved. The current prophylaxis options don't satisfy all the medical needs in terms of quality of life and bleed protection, as Dr. Konkle has nicely pointed out. More effective and less burdensome therapies are really needed to close the prophylaxis access gaps and also to help us achieve health equity among people with hemophilia. So when we're talking about these future prophylactic therapies, we really should be aiming to enable people with hemophilia to achieve a quality of life that's similar to those without hemophilia. So I'm going to give you the overarching punchline about the non-factor therapies, and that's that they really share amongst them key similarities that I think can improve the management of people with hemophilia. First principle that we need to be clear on is that they are only prophylactic agents. What that means is they can prevent bleeds usually quite effectively, but you will still require concomitant use of other hemostatic agents for breakthrough bleeds or with surgeries. Because these are not factor replacement therapies, we're typically acting on the natural anticoagulant pathways of coagulation. These can be effective in both hemophilia A and B and may also be used in people with and without inhibitors. So they're equally effective in all of these groups. So this is really a step towards increasing the number of treatment options available for persons with hemophilia A and B with and without inhibitors. You've seen the peaks and troughs of factor replacement therapy. What's unique about the non-factor therapies is there really are no peaks and troughs between the doses, and we have a principle of steady state hemostasis for the most part. From a treatment burden perspective, these are generally delivered subcutaneously, and they typically have a very reduced frequency of administration compared to the factor replacement therapies and the bypassing agents. There's multiple novel therapies that are aiming to rebalance hemostasis, and these may improve the management of people with hemophilia. There's a range of clinical development programs that are advancing. So the target sort of in the middle, these are the marketed therapies, and you can see that are several that are approved, but also others that are on the cusp. And then in the blue and the purple, we see some of these programs that are in various stages of clinical development. And we hope to see these all sort of move towards being marketed eventually. So we'll start with the first agent that was approved as a non-factor therapy, and this is emicizumab or Hemlibra. And so across the top, Dr. Konkle has shown us the role of factor VIII and factor IX in coagulation. What we want to focus on is specifically the role of the activated factor VIII. And what it does is it acts as a scaffold in coagulation, and it helps to bring factor IXA together in proximity to factor X so that it can catalyze the activation of factor X and advance coagulation. The challenges of factor VIII, has been already discussed, is the relatively short half-life of factor VIII, somewhere between 6 to 10 hours, depending on the age range of the individual. And that's why we've had these peaks and troughs of factor replacement therapy. The innovation with emicizumab is instead of replacing factor VIII, we're substituting for factor VIII using an antibody. And this antibodies like to bind proteins. And so this has been designed as a bispecific antibody with one arm of the antibody able to bind to factor IXA and the other arm able to bind factor X, bring them in proximity together, and helps catalyze the activation of factor Xa. But the several advantages of this product. First of all, antibodies are very long-lived in coagulation. And so this antibody, after a single injection, will last in circulation with a half-life of about 28 days. And it can also be given subcutaneously and has very good bioavailability. So what happens is after a series of loading doses, you take the patient up to a steady state level. And then as long as you can continue regular dosing, either at weekly, every 2 weeks, or every 4-week doses, you maintain a steady state of improved hemostasis. It's not normalized hemostasis, but it's enough to serve as an effective prophylactic agent. How effective? Well, this is looking at annualized bleeding rate of patients who've been on a long-term prophylaxis with emicizumab. This is from the Haven trials, and this includes patients with, these are adults and pediatric patients, as well as those with and without inhibitors across all of these programs. But really, on the whole, you can see that within the first 6 months, patients are able to achieve a very low annualized bleed rates, generally less than 1 or close to 0. And these are sustained over very extended periods of time. If we look at the proportion of participants who have 0 treated bleeds while on prophylaxis with emicizumab, this increased over the first year of treatment and really remained above 80% thereafter, as long as they remain on prophylaxis. So what other novel therapies would fit in this category of non-factor therapies? Well, the next section we're going to talk about really are not substitution therapies, but are considered sort of rebalancing therapies. So we've talked about so far factor VIII and factor IX replacement therapy, where we're replacing the missing molecules. A substitution therapy, emicizumab, which substitutes for factor VIII. I'm going to tell you about some next generation therapies, which are trying to improve on some of the characteristics of emicizumab. And then we're going to talk about the rebalancing agents, which target 3 of the natural anticoagulant pathways: tissue factor pathway inhibitor, antithrombin, and activated protein C. And I'll tell you about how these work in a minute. So what's coming next related to potential improvements to the non-factor therapies? Well, Mimate is a next generation factor VIIIa mimetic. It's also a human bispecific antibody. It has a similar mechanism of action of emicizumab, but it's had some improvements to the way that it binds the molecules, particularly how it binds and stimulates the factor IXa portion. And what this leads to is a substantial improvement in its potency, about 13 to 18 times more potent than emicizumab, at least in the in vitro, in the animal preclinical models. But we also see that in the effect on coagulation in humans. And with this study below is showing that there's about a logarithmic shift in the potency of this molecule, which means that it could provide effective prophylaxis at much lower doses, probably in the range of 10 to 15 fold lower doses of plasma levels in order to achieve the same degree of bleed protection. So this is moving through the clinical trial programs. Another strategy is NXT007. This is also a next generation factor VIIIa. And here, the original manufacturers of emicizumab have done further optimizations to the emicizumab molecule. And what they've been able to achieve is a comparable activity to emicizumab at about a 30-fold lower concentration. And for the first time, maybe with this molecule, we can see that they are able to achieve improvements in thrombin generation. Remember that thrombin generation is what really drives clot formation. And this is pushing plasma thrombin generation really into the non-hemophilic range for the first time with these bispecific antibodies. Now, with some of the modifications here, we'll talk about what potential risks related to this, but anti-drug antibodies have been observed in the clinical trial program. Maybe we'll talk a little bit more about that at the next webinar. Now, I said the next series of products fall under a category that have been considered a rebalancing therapy. So what this slide is depicting are the procoagulants, those proteins which are driving clot formation, thrombin generation, and then ultimately conversion of fibrinogen to fibrin. And in the deficiency states of hemophilia, where we're missing factor VIII or factor IX, the balance is tipped because all of the natural anticoagulants are still there in their full force. And so that balance is tipped towards a bleeding state. So what we've been doing for years is either to rebalance has been to replace factor VIII or factor IX, or more recently to substitute for factor VIII with a bispecific antibody. But it's also true that we could help rebalance this coagulation if we could impair or knock down the levels of these natural anticoagulants. And it turns out that there are programs that are targeting all of these molecules. So the three that have advanced furthest are targeting tissue factor pathway inhibitor, antithrombin, and activated protein C. And so the anti-TFPI therapies tend to be monoclonal antibodies, which bind and impair its function. There is a program, fitusiran, which lowers the levels of antithrombin in the plasma. And then there are a couple of different strategies which are targeting activated protein C to decrease its presence in the plasma and improve thrombin generation. So let's talk about the anti-TFPI agents first. So tissue factor pathway inhibitor is a type of regulator in coagulation that downregulates the generation of factor Xa and 7a tissue factor, and then in turn thrombin generation. So it's a good target if you want to improve thrombin generation to impair the function of this molecule. These monoclonal antibodies that have been developed have a high bioavailability when given subcutaneously. They have stable pharmacokinetics. So again, that steady state hemostasis we mentioned. And because we're targeting this natural anticoagulant pathway, this can be used in people with hemophilia A or B with or without inhibitors. We'll talk more about the challenges of these molecules at the next webinar. Because of some specifics related to the pharmacokinetics of this particular anti-TFPI strategy, concizumab, this drug delivery has to be given on a daily basis. But what has been developed is a really, I think, slick delivery device, really as a pen, similar to what has been utilized in some ways to deliver insulin for patients with diabetes. But this is a very small needle, a daily subcutaneous injection. If we look at the bottom, this is a highly effective prophylactic therapy. Here, looking at patients who are on demand therapy with the kind of annualized bleed rates you've seen presented earlier today, but on regular concizumab prophylaxis, patients were able to achieve excellent bleed control. Marstacimab is a alternative anti-TFPI therapy. It's already demonstrated efficacy and safety in the phase 1/2 studies with long-term administration at this dosing on a weekly subcutaneous dose at 450 milligrams, again in Hem A, Hem B, with and without inhibitors. The phase 3 trial is ongoing in adolescents and adults. There's going to be a 6-month observational phase to collect bleed data, and then patients will be followed on demand on their prior therapy or routine prophylaxis with this therapy. And they've chosen to have a loading dose followed by a 150 milligram weekly strategy for this prophylaxis, and we'll have to wait for the results from this program. Next therapy is the antithrombin lowering strategy, and I'll tell you about this small interfering RNA molecule that achieves this. But why is this a good target? Antithrombin is a natural anticoagulant, and it's the major physiologic inhibitor of thrombin, as well as factors 10A and factor 9A. If you lower antithrombin or impair its action, you will improve thrombin generation. The strategies that have been targeting this have achieved a sustained effect of lowering antithrombin to very low levels and getting really substantial improvement in thrombin generation. We have mechanisms to monitor antithrombin. These strategies have low immunogenicity. And again, the aim for this strategy is that it could be used in people with Hem A or B with and without inhibitors. So what is an siRNA? This is a small interfering RNA molecule that after injection gets taken up by liver cells, which is where antithrombin is made. And it has a conjugate onto it so that it gets recognized by specific receptors on the surface of the hepatocyte, gets taken up into the cell, and then it gets incorporated into this inhibitory complex, which basically blocks the ability of the messenger RNA to produce any more protein. And so as soon as this molecule goes into cell, antithrombin production is essentially halted. So this is fitusiran. It's an investigational subcutaneous prophylactic siRNA therapeutic. It's really designed to specifically lower antithrombin and then restore thrombin generation to drive this rebalancing that we've talked about. Notably, about 10 to 15% of people with severe hemophilia may have some component of antithrombin decrease, which will improve their thrombin levels and therefore have a milder bleeding phenotype. So there's already a proof of principle from natural aspects of this strategy. So this has been examined in phase 3 trials. These are the 3 core programs in hemophilia A and B with and without inhibitors, in Hem A and B with inhibitors, and then a prophylaxis strategy. So in these first 2 groups, patients came on demand onto fitusiran and followed on prophylaxis after initiation on fitusiran. In the Atlas prophylaxis study, they were on regular prophylaxis with either factor therapy or bypassing agents, and then switched to fitusiran. So what happens when you knock down the antithrombin levels? You can see that very quickly the antithrombin levels fall to about 10 to 20% of the normal level. These are patients who are untreated. These are those who have received antithrombin. As long as you receive continued dosing with fitusiran, your levels stay down at this level. And what we see concomitantly, this is a measure of thrombin generation, and your thrombin generation goes up, mirroring this decline of antithrombin. And what's not really shown here is that the normal healthy volunteer range of thrombin generation starts about here. So some of the patients on fitusiran, their thrombin generation is starting to overlap with the lower bounds of the healthy volunteer population. So what happens when you shift from on-demand on your prior therapy to fitusiran prophylaxis? Well, regardless of whether you're hemophilia A or B or have an inhibitor, about 90% improvement in the annualized bleed rate. So a highly effective prophylactic therapy. But I think the real insight comes from the prophylaxis study. This was during the observation phase. Patients were on either factor replacement or bypassing agent prophylaxis. He may be with or without inhibitors. And what you can see is that they had a median observed annualized bleed rate of over 4, and a minority of patients experienced 0 treated bleeds, only about 17%. But after the switch to fitusiran, the annualized bleed rate fell to a median of 0, and the majority of the patients, about 63%, had 0 treated bleeds. The next program we're going to talk about are using targeting and activated protein C. And again, activated protein C is regulating primarily factor 5A and factor 8A to degrade them and reduce thrombin generation and impair blood clotting. So it's a good target. The first program I'm going to talk about is called SerpinPC. This is a serine protease inhibitor that specifically targets activated protein C, essentially mops it up in the plasma. It has a long half-life, it has a high bioavailability when it's given subcutaneously. It's got a low immunogenicity itself, and again, can be used in people with hemophilia A, B, with or without inhibitors. So this has been still fairly early in its clinical development, but in this phase 1/2 trial, trying to identify the optimal dose, you can see either using an every 4-week dosing or an every 2-week dosing, there was substantial improvement in annualized bleed rate, shifting from on-demand therapy to prophylaxis with this agent. And then we just got new data on an extended follow-up of patients who are on an every 2-week dosing regimen. And here we can see the intra-individual comparison. So this was the individual patients on their baseline ABRs. You can see there was substantial bleeding in this cohort of patients. This includes both Hem A and hemophilia B. And then after continuing on prophylaxis with SerpinPC, you can see a significant proportion of these either had 0 bleeds or very few bleeds, but essentially all of the patients showed improvement with an overall median ABR quite low at 1.0. There's another strategy that's also targeting activated protein C, and this is an antibody, SR604, which again specifically recognizes activated protein C. So this is very early in development, but the first patients are probably going to start being evaluated in a phase 1 study in this coming year. So in general, what we can say about these non-factor therapies is they absolutely will reduce the treatment burden for people with hemophilia. In general, they require less frequent administration than existing treatment options, and they can essentially be given subcutaneously. It's a range of frequency, and here all the programs we've talked about can range from either once daily with one of the anti-TFPIs, but once weekly, perhaps even once monthly, or for fitusiran, even the revised dosing strategy is every other month starting dose. So I think this less burdensome prophylaxis really could improve potentially treatment adherence. It will lead to increased use of prophylaxis and potentially improve quality of life of people with hemophilia. they really can also widen the therapeutic options, since they can be since they're being evaluated and they're showing efficacy in people with hemophilia A, B, with and without inhibitors. They're really opening up new options. These non-factor therapies are not neutralized by pre-existing anti-factor VIII or anti-factor IX antibodies, nor do they seem to elicit an immune response for the most part, at least against factor VIII or factor IX. So that's why they're such effective, so effective in the inhibitor population. And we've not had a non-factor therapy option for people with hemophilia B, and particularly those with inhibitors who really have struggled to have an effective prophylaxis strategy. So I think we can see how these therapies really could provide accessible therapeutic options for all people with hemophilia, particularly maybe in resource-constrained countries, as the WFH really works to alleviate some of the treatment disparities. These emerging therapies may offer more therapeutic options that can be incorporated into the global schema. And in general, this less burdensome therapy, I think, is a real step forward for patients with hemophilia. So these therapeutic options, I think, can address some of the ongoing unmet needs and really help achieve health equity among people with hemophilia, particularly those with hemophilia B and hemophilia B with inhibitors. They all are aiming to restore thrombin generation and to improve options across the board for people. Now, in the last few minutes, they wanted me to cover just some general principles of gene therapy before we wrap up today. So what we've talked about so far are the factor therapies, standard half-life and extended half-life. And these are the peaks and troughs that Dr. Konkle had shown. Really no real key paradigm shift for the extended half-life factors, except maybe reducing the burden of the therapy, maybe improving the target troughs. But with the non-factor therapies, it really is a paradigm shift. There's no factor level that is being achieved with these therapies because they don't replace the missing factor, but they do provide a paradigm shift in achieving steady state prophylaxis. But what's really driving the ideas about gene therapy is that we would have measurable factor levels, but they would also achieve steady state hemostasis. And so in a sense, it would be the best of both worlds. So the goals of gene therapy are just to increase factor levels on a steady state basis. This would reduce the annualized bleed rate, reduce the burden of therapy for patients. They would certainly have reduced clotting factor concentrate use. There'd be reduced anxiety because of that protection on a regular basis. And we hope that it would improve quality of life. So this is the basics of how gene therapy works. With gene therapy, a transgene, so factor IX or factor VIII transgene, is packaged into a viral vector that's then delivered to target cells. In this current mode, we're targeting hepatocytes in the liver primarily. And then once it gets into the cell, the vector is unpacked, and the transgene is delivered to the nucleus of the cell, where it starts to make the protein. It gets secreted into plasma naturally. And then the components of the delivery are then broken down, and, if you like, recycled. And really, the analogy that we use in talking about this with patients is kind of like a delivery box situation. So the vector is the box, the transgene is inside the box gets delivered to the liver, the box is emptied, and then the components are recycled by the body. So who's getting gene therapy? Well, in the clinical trials to date, and in the couple of instances where it's been approved, it's only for males who are 18 years or older with severe hemophilia, or at least moderate severe in the case of hemophilia B. They've all had exposure to factor VIII or factor IX in the past, and they have not even had a history of inhibitors. The adeno-associated viral vector is the primary strategy that's been used, but we are exposed to AAV naturally, even though these don't cause disease in humans, but they can generate antibodies, which in most cases have precluded the ability to receive this type of therapy. Because we're targeting the liver, we have to give it to patients who have no evidence of significant cirrhosis or fibrosis. We have been able to do gene therapy in those who have legacy issues related to hepatitis and HIV. This is sort of the overarching experience with factor VIII delivery to date. Very good levels generally within the first year after receiving these therapies, but this really disappointing loss of activity over subsequent years. For most of the programs, we don't yet know whether this plateaus at a low rate, but this has been the primary limitation of the factor VIII strategy. This is in contrast to the factor IX delivery strategies, where the expression seems to have been quite stable over multiple years. But even with the factor IX, this slide is illustrated because it shows you the wide range of expression of patients. So even though the mean and median levels seem to be in the near normal range for hemophilia, we still have patients that have either very low responses to this treatment or are in the upper bounds. And so this lack of predictability has still been an issue. We'll talk about this more at the next webinar. So what are the potential pros and cons of gene therapy for hemophilia? This is a single infusion event. It can achieve steady state hemostasis. It liberates the need for prophylaxis. And accordingly, there would be annual cost savings for every year of expression afterwards. Some patients are currently ineligible, children, those with neutralizing antibodies or factor inhibitors. We'll talk more about some of the safety issues at the next webinar. And of course, to date, at least, these have come with high initial cost. So thank you for the opportunity to share that. And we'll have some time, hopefully, for some discussion after we hear from our guests today.
Thanks, Steve, and thanks, Barb, for great overviews of the current range of therapies for hemophilia. We're going to go to the second poll now. And so this is the same question. You are a 60-year-old male with hemophilia A without inhibitors and have been on on-demand treatment with standard half-life products your entire life. Based on the information you have just learned, what treatment would you choose for yourself? Choices include continue with on-demand for standard half-life or extended half-life products, prophylaxis with standard or extended half-life products, prophylaxis with ultra-long half-life, such as Altuviiio, bispecific antibody, such as emicizumab, rebalancing agent, such as concizumab, or gene therapy. The poll is up now. Okay, and I believe we will see the results of the pre and post poll. So this is pre. That was a little fast, but I think most people would be on continue with emicizumab. And post. I don't suppose we could put both up at the same time.
Unfortunately not.
Okay, well, I think I see a few differences here, but go back to the first one if you could. Yeah, so a little more activity with rebalancing agents. So Steve, you had a little bit of an effect there. All right, Well, let's move on to our patient advocates now. And as I mentioned, we have both Hazri Aris and Enrique Preza, who will be giving some comments on shared decision-making. And in the context of the kinds of information that we heard today and that we'll hear on the next webinar. Hazri, you want to get started?
Sure. Thank you, Dr. Glenn, for the introduction. Good morning, good afternoon, good evening to all attendees. Happy to present today, although it's midnight now in Malaysia, to share my experience in the shared decision-making in shaping my treatment and care regime. Thank you to the World Federation of Hemophilia for the opportunity. I'm Hazri Aris. I'm 36 years old. I'm a person with severe hemophilia A, and I'm based in Kuala Lumpur, Malaysia. And I have an older brother, 39 years old, and 3 uncles from my mother's side who has severe hemophilia A too. A little bit of my history, bleeding history. So my target joints growing up were left elbow and left ankle, and I experienced bleed twice every week until roughly until I was 21 years old. And in the early 90s, generally the treatment is on-demand regime, and for a while I received cryoprecipitate until I was 7 years old, and we finally made the switch to plasma-derived factor VIII concentrate when it became available in Malaysia. And in those days, we had to visit the Hemophilia Treatment Center every week without fail. And in every visit, only a small amount of factor stock provided, roughly around between 1 to 2 doses for emergency purpose. And this led to limited choice of activity and lifestyle to avoid risk of bleed. And, being a small and active boy, I felt discouraged from being active at the time. However, things changed in 2009 when we switched the Hemophilia Treatment Center. In the beginning of the switch, I was still put on-demand regime, but there was a bigger safety net where we received at least 1 month stock of factor supply, which allowed home treatment, although on demand. The goal of treatment at the time is to allow bleed to, as you know, to be treated immediately. And then shortly after we changed to prophylaxis, the change of treatment regime was done, if I can say, in a shared decision-making setting, where there was a discussion with the hematologist on benefits on-demand and prophylaxis, the pros and cons. But we finally decided to go, of course, on prophylaxis, but it was still on plasma-derived factor VIII concentrate. And the new treatment regime allowed me to be more active in life, and I was able to be really active in the university, where I was in the life-saving team and swim coaching team. This led to a tremendous improvement in quality of life. And this was also made possible with the involvement of comprehensive care team, where there was involvement of physiotherapists, the orthopedician, to ensure my joints are in good condition for me to be able to do all these activities. And I was able to discuss with the team, especially my primary caregiver hematologist, on adjusting my infusion frequency and dosage according to my activity. For example, there was a period of time where I was really active. I was in the water almost every day. I went through a prophylaxis regime of five times a week infusion, low dose. And there was also a time where it's an off season. We did a low dose twice a week infusion. Currently, I'm on low dose 3 times a week. I'm still not as active as before, but we maintain that 3 times a week infusion. And in the past 1 year, there were only 3 bleeds, but those bleeds are not joint or muscle bleed, but it's because due to cuts where I can be careless at times. So cuts sometimes happen, which requires extra infusion. So in summary, I think patients and parents, new parents are becoming more interested in the advancement of treatment and care. we can see they're actively asking questions in treatment center setting or community activity setting. But both patients and treaters need to be equipped with the knowledge and tools on the best and available treatment and care to make the best decision together in achieving life goals and treatment preferences. And I believe this is where the shared decision-making tool by the WFH would be useful to foster this discussion. However, we need to consider the treatment and care scenario of a country or a hemophilia center as to not have an over expectation. But the upside is I feel that patients via the national member organization can advocate for a better treatment class in the future. So that's all for me. Thank you for your time, and I hope to see you in person at the upcoming World Federation of Hemophilia Congress. Thank you.
All right, thank you, Hazri, for that nice demonstration of how you've been able to progress with various treatment options. Next, we have Enrique, who will give us his perspective. And then I should also mention that questions can be posted under the Q&A. If we don't have time to get to all of them, we will continue them at our next webinar. Enrique?
Hello. Well, let me start. My name is Enrique Preza. I'm from Mexico, and I was diagnosed when I was a child, when I was 1 year old. But actually, I didn't receive any treatment until I was 5 years old, mainly because my parents were afraid of the virus situation in the world. So yeah, they actually didn't use any treatment, any blood treatment on me. After 5 years old, I started receiving kind of on-demand factor VIII product, mainly because I had bleedings on my left knee. And well, when I was 15 years old, there was this situation where they think I had inhibitors. I had some problems with in my mouth. But it wasn't until I was 18 years old that I had an intracranial bleed that they actually find out that I had inhibitors, and they had to treat me with FABA, with bypass agent. From 18 years old to 23, 24, more or less, I didn't receive any treatment because it was hard to find any bypass agent here at Mexico. But when I was 23, I started receiving 1 dose of FABA for the whole month. So it was more like for emergency purposes. My left knee was also damaged, and I had like a lot of problems to walk. I had to use crutches sometimes. And yeah, I mean, I study, I did high school, then I did university and my career and everything, but I had like a lot of problems. Then when I was 25, yeah, more in my adult life after university, I started receiving a couple of doses per week of bypass agent. It could be FABA or it could be Novo 7, and that improved my quality of life a little bit. I mean, I still was doing rehab with my knees, and I could start like working and moving and doing like a little bit more of exercise. I must comment, because this is important for the future part, that when I was like around 18 years old, I started practicing table tennis, but I didn't have like any treatment at all. So I had to quit the sport in a year because I couldn't handle the problems in my knee and in my ankles too. So yeah, I played like for 1 year only. And then, yeah, I had problems with my joints. So let's back to the 25 years old. I could do exercise, I could swim, but I had bleeds, and yeah, I couldn't do it as often as I wanted. And I keep it that way for a lot of years. But then when I was 30 years old, I'm currently about 40. I'm going to, in April, I will be 40. But when I was 30 years old, there was this chance for me to receive emicizumab from Libra. And I accepted. I speak with the doctors, and I had kind of an active kind of life because I liked to travel, and I also work, and I had to move like a lot. But that was all. I did like a little bit of exercise, but that was all. But when I start with the emicizumab, I start going to the gym, and I start like doing like a lot of exercise, like almost 1 or 2 hours daily. And after a year, I decided to try to go back to table tennis. So the thing is that after that, I start training. And yeah, last year, I was one of the national players of Mexico to represent on the Pan American Games. And I was training like about 30 hours per week. That's quite a lot. It's actually most of my time I will be like training, like doing exercise. And I mean, I could handle that with my current treatment with emicizumab. I didn't have like any bleeding, and my problems were like more like regular athlete problems, like having pain in the muscles, but because of the high charge of exercise that I was doing. And I mean, currently I'm like fine. I understand that emicizumab doesn't work. For example, I had a surgery 2 years ago, and I had to use bypass agent because yeah, hemicizumab doesn't cover me for the part of the surgery. But yeah, currently in my daily life, even being an athlete, I'm okay. I'm like real okay. Yeah, it's funny because I know there are new therapies, and I am also in the gene therapy roundtable, and I know there is gene therapy. But actually, with my current treatment, I'm feeling like okay. So I believe it's quite important for all the patients to understand what are their needs, what they want to do, and I think that if you find out which is the correct treatment, you can go with your plans in life. You don't have like to go to gene therapy necessary, or yeah, I mean you need to find which one works for you. So yeah, I hope this works for you, and thank you very much.
All right, well, thank you, Enrique, for that also insightful approach toward how to manage the complexities of your hemophilia, including your inhibitor status. Whose idea was it when you went on emicizumab to really develop an intensive exercise program?
Well, it was mostly me because what I have read before is that I was expecting to have like zero bleeds at all with emicizumab. So I started. I had to talk with my multidisciplinary team. I mean, I didn't talk about that right now, but I actually usually conversate with them and also with the methodologist to let them know. Actually, they were kind of worried because I started doing like so much exercise, and some of my markers on my blood were like irregular for yeah for they were useful, and they were actually like they didn't know if I would have like a heart attack because one of the markers were like too high because of the kind of exercise that I was doing, and because I was testing emicizumab in Mexico, they wanted to know that everything was safe and it was only the exercise and not the product that was causing that. But yeah, it was I wanted to do that, and it also was with my physiotherapy team. Yeah, that's the answer.
All right, and do we have any additional questions for any of our panelists? I noticed that some have been answered already. Thank you, Steve. So Enrique, we have a question about what is meant by a marker for a heart attack. So are you saying that you had some enzymes that were elevated and that could represent heart or could represent skeletal muscle?
Yeah.
Okay, and so I assume it was not your heart.
No, it was not my heart, but they were not expecting to have those enzymes on my body and those high titers, and yeah, because they were checking the thing for emicizumab, they just want to be sure that everything was all right. But it was because of the high intensity exercise I was doing, and it has nothing to do with emicizumab. But they were. I mean, I was the second patient in Mexico with the emicizumab, so they wanted to know everything worked fine.
I see. Okay. Any additional questions for any of our panelists? Steve and Barb, can you give us a prelude as to what the next webinar will be and how it will tie into this one and then the last one? Barb, do you want to start?
Sure. So I'm going to talk about safety issues related to factor products, and that would include allergic reactions, infectious disease transmission, and a lot about factor inhibitors and risk factors, and then to talk about how we might balance the benefits and risk when we're thinking about those therapies.
And then I'm going to be addressing some of the safety issues that we have to be concerned about related to these novel therapeutics, the non-factor therapies, as well as gene therapy. We've had more than, well, you said 1992, Dr. Konkle, related to, recombinant proteins, but really for factor replacement therapies, we have 50 to 60 years of experience of using these therapies in every clinical context, but we're only very early in the stage of evaluating these novel products with current patients. And so there's a lot to learn. And one of the principles we're going to be talking about at the next webinar is this issue of risk mitigation. So when you use these agents, you have to learn how to use them properly and how to use them safely. And so we'll dive into that a little bit more.
All right. Thank you. And Enrique, you're going to answer a question from Natalie?
Yeah, it's okay. I mean, I can answer it in English. She's asking that it has like 10 years in treatment with emicizumab, I believe. If I actually start when emicizumab was at investigation. Yeah. When I started in Mexico, the treatment was already viable. Emicizumab was already viable, but it hasn't been introduced in Mexico. So there's this like stage where they test with some patients to know if it's going to work. So the treatment was already viable in other parts of the world, but in Mexico it was just like the beginning. I was one of the first patients to receive the treatment, just like a protocol to see if it's going to work in the sociocultural environment of the country. And yeah, I mean, it did work.
All right. Thank you, Enrique. And thank you to all of our panelists for a very stimulating hour and a half. We will continue this on March 12th, I believe. March 8th. No, March 12th. I thought so. And then March 26th. So with that, thank you all for your attention. This will be posted on the website in the next 1 or 2 days. Bye-bye, everyone.